For those of you who don't know me, my name is Andrew Cowan, and I'm the clinical director of multiple myeloma at Fred Hutch. Today, what I'm going to be talking about, I'm going to be kind of setting the stage for our fabulous speakers that are coming after me, talking a little bit about where we are with current myeloma upfront therapy, talking about really some of the very fascinating history of CAR T cells and how we got to where we are. I'm going to let my colleagues, Dr. Banerjee and Dr. Cicero, talk a little more in detail about those therapies, but I'm going to kind of bring you all up to speed on how we got there, because that's actually a really fascinating history. But to start, I'm going to kind of talk a little bit about where we are today. And I know a lot of you, this is very familiar, but I think, most of us, the faculty, were just at the International Myeloma Society meeting in Athens, and so that was a couple weeks ago. I can share with you kind of some recent updates from that. I think that there's some new thoughts about what constitutes high risk that I think are probably, going to change some of our practice. For patients who are newly diagnosed nowadays, we would typically start, I think most of us are kind of routinely utilizing the 4-drug combination. So that's the RVD DARA or DARA RVD, or sometimes maybe DARA KRD. And so, for anyone who was treated maybe, 5 or 10 years ago, that's a shift, right? Because I think, 10 years ago, we were still using Cyborg-D, and then 5 years ago it was RVD, and now we have a 4-drug combination. And I'll explain some of the data for why that's become more routine. 3-drug combinations are still used. I guess, it's, if we're going to be consistent, I struggle to see where I would use that in a patient who is transplant eligible. But certainly they're still used, and they work, and, it wouldn't, necessarily be wrong to use one, but I think that, the data for the 4 drugs are just so compelling. And then stem cell transplant, even with these really, really effective therapies, is still a very important part of treatment. And for someone who's eligible, which is typically based not just on age, but on sort of overall assessment of fitness and functional level, we do recommend that. And then for maintenance, lenalidomide has yet to be toppled off the throne for sort of most patients with multiple myeloma, although there are some really promising drugs, the CELMoDs, iberdomide and mezigdomide, and iberdomide in particular may have a much better tolerability profile. And so, my hope would be, and I'm sure we'll see studies of this in the future, that we can investigate some of these other CELMoDs as potentially alternative approaches for maintenance for standard risk patients. But lenalidomide is still kind of the standard. And for high risk, typically, I think most of us who treat multiple myeloma across the country tend to prefer the 2-drug combinations for a prolonged period of time, typically a proteasome inhibitor like Velcade or maybe carfilzomib, plus an immunomodulatory agent, or a CD30 agent in IMiD. And I think there's data that can support each. For patients who either don't want to do a transplant or are not transplant eligible, the DARA-RD combination is very powerful. That's a very effective combination. In my opinion, for me, that's kind of what I generally give for the non-transplant eligible patients, mainly because there's no neuropathy. And neuropathy, as many of you know, is so impactful. I don't need to tell this crowd that. It can be so tough, even if it's grade 1 or 2. We in oncology, we grade neuropathy, and we'll say, oh, it's just a grade 2. But that can be really tough. I mean, that could be, you can't get up some stairs because you can't flex your foot. I mean, neuropathy is a big deal. And in my opinion, if we can avoid neuropathy, that's a win. So DARA-RD is a very powerful combination, but so is RVD. And there's actually going to be a study that compares the two, run by one of our national cooperative group trials. So it'll be really interesting to see what the results of that are. And that study is open now, I think, at some places across the country. And then supportive care is a very critical part of myeloma treatment, and it begins from the time of diagnosis throughout. And that's not the focus of what I'm talking about today. You'll hear about that from some of the other speakers. So what are the data for the 4-drug combination? I'm going to review this briefly. I know many of you are familiar with this, but just so we're all on the same page, it was the Griffin trial, of which we were a site at Fred Hutch. My colleague, Dr. Silberman, was also one of the PIs at OHSU. And so this was a randomized phase 2 study. Most of our studies that are randomized are phase 3, but this was a phase 2. Don't let that detract from the findings. So the study compared the DARA-RVD combo to the standard RVD, which we used to use for many years, combined with transplant, consolidation, and maintenance. And just the biggest difference here is the maintenance that patients received who got DARA. They got 2 years of daratumumab maintenance plus lenalidomide, and then continued lenalidomide after that. One question that commonly comes up is, what's the deal with consolidation? I mean, that's not something we normally do, and this is something that is a pet peeve of mine that seems to persist as sort of a study design for clinical trials in multiple myeloma. Just know that consolidation is not something we generally do. We typically would kind of try to get the maximal benefit with the treatment before transplant rather than giving more therapy afterwards, although sometimes we do. It's just not that common. So basically, this study compared the RVD to the DARA-RVD. All the patients got a transplant, and then DARA-R maintenance or R maintenance. The primary endpoint, which is how the folks who design these studies decide what is important about a study, was the rate of stringent CR at the end of consolidation. And what stringent CR means is no evidence of monoclonal protein in the blood or the urine, normal free light chains, and a bone marrow biopsy that's negative by flow or by in situ hybridization. And so this study met that endpoint. They showed that there was a dramatic improvement in the rate of stringent CR in the patients who got the DARA-RVD combination. And overall, the response rates were very high. You can see that 99% of patients responded. So we are now in an era with modern induction therapies where we're seeing almost 100% of patients respond, which is just incredible. The other take-home point of this, and these were data that were presented by my colleague and friend, Dr. Saborov from Utah at the IMS meeting last year. The other take-home point is MRD negativity rates deepened over time in the DARA-RVD group. And you can see this shown nicely here. The percentage of patients who achieve MRD negativity, and the test that we often use to test for this is a PCR test. Typically clonoSEQ is the assay that we use. And there is a dramatic difference, as you can see here, in the percentage of patients who achieve that MRD negativity, which, as all of you know, is associated with better long-term outcomes. And MRD negativity is often what we talk about when we talk about a goal for treatment. And so I think it doesn't a picture tells 1,000 words here, and you can tell that this is just the DARA-RVD transplant, DARA-R maintenance is a very effective, powerful combination for achieving deep responses. The time to MRD negativity was also improved, and it looks like patients who are achieving MRD negativity, most of them are going to get there by 9 to 12 months. And you can see that we just get much higher percentage of patients getting to that MRD negative state with the DARA-RVD treatment, and you can see that in the top dotted line. The other thing that we look at in oncology is what we call progression-free survival. I'm not going to get into the weeds on this, but just you can kind of think of this as like how effective a treatment is at keeping someone in remission. Remission, remember, we know that remission doesn't mean it's gone away and it's never going to come back, but we know what remission means in myeloma is that there's no evidence of disease in the blood and things are not progressing clinically. And so the DARA-RVD improved that. At 4 years, the PFS rate for the DARA-RVD combination was 87%, which is really remarkable. The other study that really I think is important in the modern era, and this is the determination study that many of you are familiar with here. This was the study that was performed in the US that compared RVD followed by lenalidomide maintenance to RVD transplant and len maintenance. And so the question here, remember the question with the Griffin study was, is DARA-RVD better than RVD when we use a transplant? The question here was, is RVD alone equivalent or not as good as RVD plus transplant, because even 5 or 10 years ago, folks were asking, well, gosh, RVD is so great, maybe we don't need to do transplants. And so that's kind of where what the impetus for this study was. And you can see here that, even with the RVD regimen, which isn't quite as good as Dara-RVD, we're still seeing a pretty significant benefit in terms of how long folks stay in remission when they get a stem cell transplant. And so this is the data. These were published last year. The former clinical director of our program, Dr. Libby, was very involved with this. Many of you know Dr. Libby, and he was one of the co-authors on this paper. So we contributed quite a bit to this study. The other thing that I want to mention, and this is a shout out to Dr. Silberman, wherever she is, one of the later speakers, is looking at quality of life in patients receiving these regimens. I think one thing that commonly comes up when we talk about adding drugs or adding therapies is how is this going to impact my patient's quality of life? Or from a patient standpoint, how is this going to make me feel better? Because really, we don't just care about living longer, we want to feel better. We want to have better quality of life. And I am really pleased that this was part of this study, because these types of assessments are so important to understand how our therapies affect patients. And so they included these PRO assessments, which are basically questionnaires that assess how people are feeling, their functional status, on several different domains. And I'm not going to get into this because I don't think we have quite enough time, but just know that these are questionnaires that assess how people are doing in terms of quality of life. And what they showed on the Griffin study was that both Dara-RVD and RVD resulted in reduction in pain symptoms, which is, I think, anecdotally, which is, what we observe when we start treatment, is that we see improvement in disease-related symptoms. Fatigue symptoms were also better, and in particular, they noted that patients who got the Dara-RVD regimen had a greater reduction in fatigue symptoms at maintenance month 24, which is really important, especially when we're concerned about treatments adding fatigue. It actually seems like the daratumumab arm, patients had less fatigue over time. So that's a counter argument to saying, adding more treatment makes things worse in terms of fatigue. It's actually not what the data show. So switching gears a little bit, I'm going to talk a little bit about high-risk multiple myeloma. I know this is a common topic, at least in my conversations with patients, what's high risk? What do we do about high risk? How do we manage it differently? And, I think this is something that is an evolving field. Certainly there was a lot of chatter or discussion about this at IMS, and, some potential new ways of thinking about high risk were presented. So I'm going to go over, what we consider to be high risk. In particular, I would say the presence of 2 or more high risk features. And, for those, who are familiar with this, remember the high risk we define by the FISH changes, the chromosomal changes in the myeloma cells themselves. And the ones that I'm sure many of you are familiar with for high risk would be the deletion 17p, the chromosome translocations between chromosomes 1416, 414, or 1420, and the 1q gain, or amplification or duplication, depending on which nomenclature you prefer. And so if you have 2 or more of those features, that consistently seems, and I'll show you some of this data, to be associated with the highest risk of having more aggressive type of myeloma. When I say more aggressive, it just means myeloma that is more likely to come back. But a caveat to all this is that I would take these high-risk markers as almost, like a horoscope in the paper. They're certainly not perfect, And, the question comes up a lot, Doc, I was high risk when I got diagnosed. That was 10 years ago. I've been on maintenance for 10 years. Am I still high risk? And, I think, yes, we would have said you were high risk when you got diagnosed 10 years ago, but now it's been 10 years and you're still on maintenance, and that's not behaving like high risk. What does high risk behave like? This is what high risk behaves like. So this was an analysis from the Griffin study and the MASTER study looking at patients who got frontline daratumumab-based quadruplets, and they basically analyzed the impact of having either no high-risk markers, 1 high-risk marker, or 2 or more high-risk markers. And, don't I don't want to make too much of this here, but this curve here, remember this is the progression-free survival. This is the percentage of patients surviving without progression. You can see here, this curve right here looks dramatically different from these other two. And that's the folks who had 2 or more high-risk features. And we see that not only in terms of survival, but also the progression-free survival. And this has been duplicated in other analyses. So it seems really that nowadays, one high-risk feature is still something we would take seriously, but it's the 2 high-risk features that I think really are becoming more of a sort of defining feature of what we would consider to be high-risk multiple myeloma. So how do we manage high-risk multiple myeloma better? There's a bunch of approaches that have been studied. I'm going to highlight 2 that I think are most interesting, but I'll also make a comment. And I think the comment is these approaches are really exciting. They're resulting in better outcomes for high-risk patients. However, they have a high burden of prolonged treatment. Prolonged, as my colleague Dr. Banerjee would say, time toxicity, which is the amount of time that you have to spend in the infusion center, or going to pick up prescriptions, or dealing with Revlimid, toxicities, which everybody is familiar with. And so that, to me, is where we really need to improve, because I really feel like this is a lot to try to accomplish, and I think it's challenging to try to adhere to these very complicated treatment regimens that almost seem like, for those that are familiar with this, acute lymphoblastic leukemia, which is a disease that's most common in younger adults, has a very complicated multi-year treatment regimen that is very difficult to get through, and that's what this is starting to look like to me. So enough commentary. What are the studies? So this was a study from England. It was called the Optimum MUC9, and basically, if you were high risk, patients on this study got Dara-RVD, followed by transplant, followed by Dara-RVD, followed by Dara-VR, followed by Dara-R. So this is a lot more involved than the sort of Griffin regimen. And sorry, that's Dara-CRVD. So they added Cytoxan, and they compared it to sort of a group of patients from another study who were similar. So it's not really a randomized study. So this is how the treatments were given. And, what they showed was, pretty, if you compare to sort of an analogous group of patients who got a lesser treatment regimen, the patients on this Optimum did much better. So, it's certainly encouraging that we can sort of move the needle with high risk. But again, my criticism is this is a lot. This is a lot of treatment. Same goes for the GMMG HD concept study. This was presented also at IMS. The paper was just published in a large journal called the Journal of Clinical Oncology. So it's out there now. And basically, this was a study for patients with high-risk multiple myeloma, and it was those ones that I mentioned, the 1Q gain, del-17p, 1416, 414, 1420, plus revised ISS 2 or 3. Those patients were eligible for the study if they were newly diagnosed, and they got isatuximab, which is another CD38 monoclonal antibody, with KRD. And this question of whether carfilzomib is better for high risk is something that's still, I think, debated amongst experts in the field, but I'm not going to get into that, but that's what they used in this study design. So patients got ISA-KRD, transplant ISA-KRD, and then ISA-KR maintenance for 26 cycles. Again, so this is a high burden of treatment. They showed pretty impressive results, though, as one would expect based on the results of this other study. They got 67% of patients in the transplant-eligible arm achieving MRD negativity, which is pretty incredible for a group of patients who traditionally haven't done that well. I'm going to skip over this stuff in the interest of time, but I think, suffice to say, there's been a lot of work done in high-risk multiple myeloma. There's a lot more work that will be done using CAR T cells earlier, using bispecific antibodies earlier. I think those are really exciting, especially using CAR T cells. Maybe there's a potential for, even in high risk, having very few drugs for maintenance, or maybe having no drugs for maintenance. Maybe that's a little bit too ambitious, but I think we can get there. So the summary so far, the quadruplet therapy with CD38 and RVD improves PFS, improves MRD negativity, and also improves health-related quality of life as assessed by PROs. The high-risk multiple myeloma is still a challenge. I feel that the burden of treatment is an issue, and that's something we need to work on. But I think if we can move the needle for outcomes, that's still a win. So shifting gears a little bit, and I'm going to try to set the stage for my colleagues. What is a chimeric antigen receptor? So we're kind of going to start talking a little bit about CAR T cells. So this came from a publication by Brian Till and Ollie Press. Ollie Press used to run the lymphoma group at Fred Hutch. This is from 2009. And what they're talking about in this publication was the idea of combining, and I'll explain this, so don't worry, a TCR complex with the specificity of an immunoglobulin to create what they called a CAR TCR. I think this is amazing. I mean, they were studying this, Dr. Press and others at Fred Hutch, long before this became a commercialized therapy. So we have a long history of innovation in this area at Fred Hutch. So why do this? Well, what the TCR complex does. So what is a TCR? T cell receptor. This is found on the surface of T cells. This is the protein that lets a T cell kill another cell that's infected or has a virus or another cancer cell. The problem with a TCR complex as sort of a therapy is that it requires another protein to bind to it called the MHC complex. And so it's more logistically challenging to design therapies utilizing a TCR complex. What they noted, them and others noted, I just want to also be clear, these were Dr. Press and Dr. Till were not the first to notice this, was that an immunoglobulin, which is an antibody, right? These have a much greater ability to bind specifically to other markers on a cell surface without having another signal required. And so they said, well, what if we combine an immunoglobulin with a TCR complex to try to create T cells that can kill cancer cells? And they called it a CAR TCR, which is pretty prescient, I would say, in terms of what came in the coming years. So this led to this work and others at other institutions like Memorial Sloan Kettering led to this explosion in the early 2010s of these therapies, trying to develop these therapies called CAR T cells. And they were first studied in lymphoma, as many as you know, with the target of CD19. And they improved on the CAR, the protein on the T cells that lets the T cell recognize the cancer cell. They used to talk about first, second, third generation CARs, and I think that's kind of a moot point now. But just know that these iterations are what have led to us having effective CAR T cells. CARs are synthetic molecules designed based on principles of T cell receptor. Remember, I talked about that, and also signaling through the T cell to tell the T cell to attack the cancer cell. CAR T cell manufacturing is a very involved process, as some of you might know. Right now, the biggest bottleneck for creation of CAR T cells is really the leukapheresis. If we want to do a leukapheresis for a multiple myeloma patient getting Carvykti or a Abecma, we have to compete with every other product at our center. So there's only a certain number of slots to do leukapheresis. And so this is probably, I guess at this point, maybe our biggest limitation, because leukapheresis and manufacturing is a very intensive process, requires a lot of resources. So basically what we do is we take the T cells, we select them out from a product, they get transduced with a lentiviral vector. So we actually use a virus to inject the DNA into the T cells. It's really cool. This is basically genetic engineering. And then we expand the T cells using proteins called cytokines. And then we formulate a product. And then we purify it. We have to make sure it passes all the quality control testing. And then we get it ready to give to the patient. I know I'm almost out of time here, but my colleague Dr. Banerjee is going to talk quite a bit about CAR T cells and bispecifics. And so I'll just set the stage by saying, where are we now? We have approvals for cilta-cel and ida-cel. These are BCMA CAR T cells in 2020, 2021. We have been treating patients for almost 2 to 3 years now with commercial products, and the current approval is only for folks who have already had the kind of Griffin-like therapy, the CD38, the IMiD, the PI, and more than 4 lines of therapy. Although I think probably in the next year we'll see that the FDA will, based on the CARTITUDE-4 study, say that we can give CAR T cells to folks who've had less lines of treatment. And the manufacturing problems are improving, but there's still other bottlenecks that sort of limit the availability to patients. So with that, thank you for your attention, and you can email me if you have questions, so feel free to jot this down quickly. And remember, there'll be time for questions at the end of the session, so thanks.